Good afternoon, everyone. Thank you so much for joining us today. My name is Dr. Veronica Peniotu, and I am the Advocacy and Program Manager at the National Coalition for Cancer Survivorship. We are really excited to have Dr. Michelle Mollica with us today. She serves as the Senior Advisor at the Office of Cancer Survivorship at the National Cancer Institute. In this role, Dr. Mollica is responsible for developing, supporting, and promoting research efforts focused on cancer survivorship. She has expertise in the intersection of survivorship and healthcare delivery, including the transition into post-treatment survivorship, models of survivorship in palliative care, the integration of oncology and non-oncology providers, and special survivorship populations. Prior to joining NCI, Dr. Mollica spent 10 years working clinically as an oncology nurse at Mount Sinai Hospital in New York City and at Roswell Park Cancer Institute in Buffalo, New York. We are so grateful to have you with us today.
Thank you so much for having me, and thank you to NCCS for the invitation. I'm going to go ahead and share my screen and my slides. And hopefully you can see them now. So I'll go ahead and start. Thank you for the invitation. My name is Michelle Mollica, and I am really excited to be here to talk about the National Cancer Institute's efforts focused on survivorship needs for individuals living with advanced and metastatic cancer. I am joined today by survivor and advocate Bethany Ross, who I will introduce in just a moment, but I'm very excited that she's here to share her unique perspective. Just to provide a brief overview, we'll start with Bethany's experience, and then I'll provide a bit of background about this topic area. I'll talk about some NCI activities that we've been engaging in to try to define where the research is in this area, including a portfolio analysis and a stakeholder meeting, as well as some next steps. But without further ado, I'm very pleased to introduce Bethany Ross, who will be providing her perspective today living with cancer. Bethany was diagnosed in August of 2018 at the age of 30 with stage 4 neuroendocrine cancer in her appendix and pancreas that spread to adjacent lymph nodes and her liver. She will tell you about this, but she saw 6 doctors and was sick for almost a year until she had found someone that finally listened to her. She had monthly treatments and 2 surgeries and is currently stable and gets PET scans and blood work every 3 to 6 months. Since her diagnosis, she has run 4 half marathons, gone skydiving, outdoor rock climbing, snowboarding, and most recently joined her state's roller derby team. She is an inspiration for me and for all of us at NCI. So I'm really pleased that she could join us today to provide her perspective. And with that, I will stop sharing my screen and I will put myself on mute so you can hear her. Thanks, Bethany.
Thank you so much. Thanks for inviting me and having me be part of this webinar. So as was mentioned, my name is Bethany Ross. My pronouns are she, her, and I live in New Hampshire. It's a gross rainy day here today, so it's good to be on this Zoom. So back in 2018, I actually started in 2017. I was actually running a half marathon on the Vegas Strip. I shut down the Strip at night and you get to run through the Vegas lights. That week, I started to feel really sick and didn't know what was going on. I thought I was just getting like food poisoning, wasn't sure. I started vomiting every day from that point on. Every morning I would wake up and something was wrong. Came back home, went to local doctors, and I have celiac disease. So they were like, maybe you're getting gluten and like, maybe it's depression. I got more diagnoses than I can count, more pregnancy tests than I can count. Because if you're 30 and you're vomiting every morning, all the doctors assume you're pregnant. I was not. So I went through all that, local doctors, multiple tests, and they told me it was a combination of anxiety and systolic vomiting syndrome, which I'd never heard of before. And that means like you vomit and we don't know why. For me, that was not an acceptable answer. Like I knew something was wrong and didn't care that 5 doctors told me nothing was wrong, essentially. So I ended up going to Boston and went to a hospital there, and they did a CT scan and said, hey, we see this thing in your appendix, but we don't think it's anything. Like, schedule the surgery when you have time. So I put it off for a couple months, got surgery August 1st of 2018. 10 days later, I got a phone call. So 10 days, mind you, I assumed everything was fine. I got a phone call from my surgeon, and he told me, you have a neuroendocrine tumor. And I asked him how to spell it, and he told me, you don't need to know how to spell it. You don't need to Google it. So at that point, I knew, like, okay, doctor number 5's out. We're finding doctor number 6. Like, I had it with healthcare professionals. And the next few months were just a blur. I was getting told it was in my liver, it was in my pancreas, I was going to need colon resection. Like, I would get a different story, I felt like, every week. That surgeon would call me on the weekends. It was just a nightmare. And I did my own research and was like, what is going on? I'm 30. And found out that luckily I was close to Dana-Farber, and they have a neuroendocrine department and actually a neuroendocrine tumor board. So while this other doctor in Boston was telling me, like, it's the good kind of cancer, don't call it cancer, we got it all. I, in my gut, was like, no, I want scans. I want to know what's going on. So I ended up finding out that it was actually stage 4 cancer and was in my pancreas and spread to my lymph nodes in my liver. So I ended up getting hormone treatments. Mine is despite being stage 4, it's low grade. So there's a lot of research going on around neuroendocrine cancer because typical cancer treatments don't work for it because it's slow growing. But as I was going through that, I mean, like, I Googled 5-year survival rates, and for stage 4 neuroendocrine, 5-year survival rate was 27%. And at 30, I was like, so you're telling me I'm not going to make it 35? Like, what is going on right now? And I knew at that point, I just needed to learn how to advocate for myself and essentially get a medical degree about neuroendocrine cancer, because it is rare. It's getting more and more common. People are getting diagnosed with it, but it's still, most people have never heard of it. And I have to, every time I go to urgent care, I have to explain to a provider what it is and what it affects, because they have no idea. So I'm going on in August, it'll be my 4-year cancerversary. And I have been struggling with not fitting in these predetermined boxes about what it means to be living with an advanced or metastatic cancer. So I just ran into this actually while I was on a snowboarding trip with Send It, which is a great young adult cancer organization, and was trying to get into psychosocial oncology. And they told me, like, I was taking the call from the lodge, and they told me, you don't qualify because you're not in active treatment. And I was like, I have stage 4 cancer, like, in my pancreas. You're keeping an eye on a tumor. What do you mean I'm not active? And they told me, no, you have to be in chemo or radiation or have a surgery scheduled to qualify for any mental health services there. And I've heard this across when I've started to talk to people about it. This is something that happens to a lot of us, that we're living longer and the policies have not been changed to support us. So that's why I'm glad to be here and learn about what is being done to help support people like me, so that we don't end up in these, like, what do I do? I'm still alive. Why is nobody helping me situations?
Thank you so much. Thank you for sharing your experience, Bethany. And I know that Bethany's going to join us for the Q&A at the end. So, so if you have questions, we would love to take those as well. So I'm going to go ahead and share my screen one more time. And I'm going to talk from the NCI perspective. So I'll start by saying that the National Cancer Institute's main goal is to fund and steward research. I'm in the Office of Cancer Survivorship, and our goal is to improve the length and quality of life for all individuals who are impacted by cancer. But it would be helpful, I think, just to center around a common sort of definition of cancer survivor. And you all that are familiar with NCCS know that that NCCS's definition is also recognized by the National Cancer Institute. A cancer survivor is any individual from the time of diagnosis through the balance of life. And recently, NCI sort of updated their definition. It didn't change much, but it recognizes that there's many types of survivors, including those that are living with cancer and those that are free from cancer. This definition is really meant to capture a population of individuals with a history of cancer, rather than provide a label that may or may not resonate with all individuals. And there are currently over 16 million individuals in the US with a history of cancer. This number is expected to grow to over 26 million by 2040. And at the same time, there has been an increase in the number of metastatic and advanced cancer survivors. So recent data from the NCI shows this growing recognition. The graph on the left shows the increasing projected prevalence of metastatic breast cancer, as well as on the right, the decline in the lung cancer deaths in the US, half of which are diagnosed as advanced cancers. So taken together from the research, this suggests that there is a growing number of individuals with metastatic and advanced cancer and that they are living longer. So individuals who are living with advanced or metastatic cancer have in common the fact that they are experiencing what may be treatable but likely incurable cancer. So this term refers to individuals who are diagnosed with advanced or metastatic cancer or who progress to metastatic cancer. And we want to acknowledge that there isn't a perfect term. So not all of these individuals think of themselves as cancer survivors, but we're trying to use sort of this phrase to closely describe the target population. And Bethany might tell you that she likes to refer to this as a cancer badass. We love that too. I think we can't use that quite as freely at the NCI, but I think that people need to use the individual term that works for them. Some characteristics about this population: these individuals may cycle on and off treatment. It includes many different cancer types, and these individuals may have periods with and without active disease. These survivors include individuals who are treated with newer therapies or targeted therapies or biotherapies. So Bethany gave you a great perspective of someone living with cancer. And because this represents multiple cancer types and experiences, I wanted to also present you with another example survivor profile. So John Smith, in this example, in 2010 was diagnosed with stage 4 non-small cell lung cancer. At the time, he was predicted to survive less than 3 years. At the time of his diagnosis, he was originally treated with 4 cycles of chemo, but experienced tumor growth, at which time he received additional chemotherapy and experienced disease control or stability of his disease. After 6 years, he experienced another tumor growth and was treated with cycles of targeted therapy for 3 years. Most recently, after a recent disease progression, a mutation analysis detected a mutation, and he was treated with an additional targeted therapy for over 1 year with disease control. So today, John Smith has survived over 11 years since his lung cancer diagnosis. And while he has survived far longer than expected when he was diagnosed, he continues to experience long-term physical symptoms and psychological concerns. And that includes scan anxiety, uncertainty, fear of cancer progression, financial hardship related to costly treatments, waning caregiver support given the long care trajectory of his cancer, and substantial issues coordinating care among his multiple providers. So as you saw with the case of John Smith, individuals living with advanced and metastatic cancer are treated with the intention of controlling or curing their disease, and they often cycle on and off treatment, especially if their response to treatment is not durable and they experience any progression or growth. And so historically, we've focused on survivorship after treatment ends. But for individuals living with advanced and metastatic cancer, their survivorship needs are complex, as Bethany mentioned. So as a result, survivorship care is essential for this population from the point of diagnosis forward. We want to acknowledge that we're challenging the way people think of survivorship and survivorship care, but we're focusing on the needs of this growing population that are living longer and have substantial unmet needs. So when we talk about survivorship care, we fall back on the National Academies of Medicine's recommendations, then the Institute of Medicine, who called for comprehensive survivorship care that includes prevention and surveillance for recurrence and new cancers, surveillance and management of the effects of cancer and its treatment, as well as health promotion and preventive care. These complex needs necessitate the delivery of coordinated care, which often involves multiple providers. So at the NCI, we've recognized that this is a growing population that we need to attend to in survivorship research. So here are some initial activities that we've done. First, we've conducted a review of the grant portfolio to see what we're funding and the literature. We've had several discussions with survivors, advocates, researchers, and advocacy organizations, and we've held a key stakeholder meeting. Overall, the goal here was to better understand the gap areas in survivorship research for this growing population. And I'll lead you through those activities at this point. So I'll start with our NIH National Institutes of Health survivorship portfolio. This recent portfolio described currently funded NIH grants focused on this population. It's important to note that the NCI has invested substantial funds in survivorship science for several decades, but much of this research has really targeted the needs of cancer survivors diagnosed at earlier stages and supporting survivors during and after treatment to manage short and long-term impacts of cancer and its treatment. We've had several past efforts focused on end-of-life care for individuals diagnosed at later stages, but not this population living longer with advanced and metastatic cancer. So the key questions that we aim to answer are what are the characteristics of the population studied in these funded grants? What are the primary areas of focus and research designs? And what are the scientific gaps in the portfolio? We examined all NIH training and project grant awards that received any funding in fiscal year 2020. And I'll just go through a bit of the results here to give you an overview of what these grants look like and the types of projects that we're funding. So you can see that we identified 25 grants funded across 4 NIH institutes. NCI funds the most grants in this area, with NINR, the National Institute of Nursing Research, also funding 6 grants. Most of the grants were funded using the R01 mechanism, which are larger grant projects. The R21 and R03 mechanisms are for developmental or pilot projects. And then finally, we identified 4 training grants that are focused on this topic. This slide gives you a feeling for the cancer types that are included. You can see that most of the grants included multiple specified cancer types, so breast and lung or breast and prostate. I did also want to point out that 2 grants included any cancer, but were based on the type of metastases of the individuals, and 1 grant focused on any cancer, but was based on treatment received. These grants mostly focused on adult populations, with 1 focusing on AYA or adolescent and young adult survivors, and the majority of grants included both males and females. 8 of these grants included a caregiver as part of the study, with most of those focused on the caregiver-patient dyad. We also looked at time since diagnosis for the sample, and only 6 were specified, with 4 being less than 1 year since diagnosis, and the other 2 not specified but receiving their first treatment. And there was a focus on minority or medically underserved populations in 9 grants, and you can see the examples here as specified by the lead investigator. When examining the primary area of focus, 7 grants focused on the implementation of early palliative or supportive care, 6 focused on psychosocial support, and 5 focused on physiological symptoms. and 3 focused on health behaviors, and those all focused on physical activity. The majority of grants were intervention studies, and finally, most grants followed participants for up to 6 months. So based on this portfolio analysis, there were several notable gaps that emerged and that we noticed in the funding research. First, although there was research to examine implementation of early palliative care, there is a need to examine the key components of palliative care for this population, including the timing, the delivery, and the types of providers and supportive care needs. There's also a need for longer term studies. You saw that most followed only up to 6 months. So this population is living longer, and we know that symptoms and experiences change over time. And so we really need to look at things in a longitudinal way. And finally, there is a need to be able to accurately identify metastatic and advanced survivors in the electronic health record and in cancer registry data. In addition, additional gaps included a focus on individuals treated with newer, targeted, and emerging therapies. There continues to be a need for caregiver and survivor research, including support through treatment decision-making, prognostic uncertainty, and financial hardship. And finally, models of care delivery, so how care is delivered, which should address management of long-term comorbidities or other chronic conditions, the role of primary care, and other non-oncology providers. To further explore the research in this area, the NCI led a virtual meeting in May of 2021, focused on survivorship needs for this population. You can see the meeting website on the Office of Cancer Survivorship webpage here, and that includes the agenda for the meeting, as well as a recording of our patient and survivor panel, of which Bethany was a part of. The goals of this meeting were to define the current state of research in this area, to identify health and supportive care needs, and to discuss research gaps and opportunities in the areas of epidemiology, healthcare delivery, behavioral sciences, and symptom management. This slide gives you an idea of the attendees at this virtual meeting, and this was a public meeting open to anyone. We had over 300 attendees at this meeting, with the majority including researchers and clinicians. But I want to draw your attention to the fact that 10% of attendees identified themselves as patients, survivors, caregivers, or advocates. To provide an overview of the meeting, on the first day, we had a keynote presentation by Dr. Ryan Knipp, who presented an overview of the landscape of care delivery for survivorship needs for this population. We had, as I mentioned, an engaging patient and survivor panel that could have probably taken the whole day. It was that engaging with great questions and discussion. And then we had scientific sessions focused on symptom management and epidemiology and surveillance. Each scientific session included subject matter experts that presented on specific topics within that session area, followed by an interactive panel that included the presenters in the session, as well as additional experts and a survivor or advocate who shared their perspective on the topic. The day 2 sessions focused on psychosocial research, healthcare delivery research, and health behaviors. And throughout the discussions, we captured gap areas or opportunities for future work, which I will discuss in the following slides. Some key opportunities in the area of epidemiology and surveillance include a need to develop new approaches to estimate the number of individuals living with metastatic disease, as well as identifying cohorts of individuals that we can follow long-term to study survivorship in this population. In addition, we have to leverage existing clinical trial populations for epidemiologic research on advanced and metastatic survivorship. We also need innovative technologies to capture, monitor, and manage symptoms, especially as they change over time, to characterize treatment changes, and to collect risk factor and outcome data. And finally, we need to investigate the clinical, genomic, and lifestyle factors that are associated with improved outcomes. In the area of symptom management, we need to identify survivors who are at greatest need for targeted symptom management strategies and describe factors that contribute to symptom burden. We need to understand the trajectory and mechanism of symptoms, particularly with newer therapies, and to identify key components of symptom management interventions that have been effective in early stage cancers, but could be adapted or tailored based on the needs of individuals living with advanced and metastatic cancers. In psychosocial research, there is still a need to examine and describe the psychosocial needs for this population and to create survivor and caregiver-centric models of care that address the whole person, especially at the intersection of psychosocial care and symptom management. And I think Bethany's example of access to psychosocial care, particularly for this population that may not be on active treatment, is essential and necessary for us to address. We need to identify strategies to implement prognostic tools in clinical practice and improve prognostic communication and understanding among patients, survivors, and caregivers. And finally, to develop and evaluate interventions to improve coping and address psychosocial needs. In healthcare delivery research, we need to describe care patterns, including treatments and supportive care needs throughout the care trajectory, and investigate unmet needs of caregivers as goals of care and prognosis may change. We need to understand and intervene to prevent and mitigate financial hardship, particularly with costly new therapies that may not completely be covered by insurance, and to develop and test innovative models of care, including the delivery of supportive and palliative care, financial navigation and services, as well as comprehensive follow-up care. And finally, to identify and assess and address provider barriers to delivering quality survivorship care, including management of comorbid conditions or chronic conditions, care coordination, and prognostic communication. And in the last area, key opportunities in health behaviors research include the need to develop alternative methods to capture health behaviors in studies and in clinical settings. We need to determine whether intervention approaches, models, and frameworks for health behaviors in other cancer survivor populations can be adapted and extended to individuals living with advanced and metastatic cancer. We also need to assess patient and provider practices and preferences on having health behavior discussions with these individuals, and to explore the need for formal feasibility and capacity evaluations so that we can really look at the clinical space. We recognize some cross-cutting opportunities across all of these areas. First, we need to identify existing research resources that can be utilized to investigate research questions pertaining to advanced and metastatic cancer survivorship. We need to include the survivor perspective in all phases of research on individuals living with advanced and metastatic cancers, and to investigate and address disparities among those living with this disease. And finally, to understand and address the needs of the caregiver and the caregiver survivor dyad as they relate to issues such as treatment decision-making, prognostic uncertainty, and financial hardship. So based on these gaps, the NCI has been focusing on 5 key areas for next steps. And you should see more on several of these areas to come. The first is promoting grant applications focused on survivorship research in this population. The second is efforts with our SEER cancer registry data to promote efforts to identify the population, to assess and enhance available data resources, as well as understand unmet needs in a variety of areas, including physical symptoms, psychosocial concerns, care delivery needs, and other challenges. And finally, enhancing the awareness of the need for research. And in the area of promoting grant applications, I am so pleased to share that we recently published a notice of intent to publish a funding opportunity announcement. This is indicating NCI's intent to publish a request for applications, or an RFA, with the goal of supporting R01 grant applications to better understand and or address survivorship needs for individuals living with likely incurable cancers. This RFA is expected to be published in later this spring, with the first application due in the fall. The link for the notice of the intent to publish is here, but I expect that you will see more to come. I want to drive home that this investment demonstrates NCI's commitment to growing this area of research. And it has been, we took all of the feedback from the meeting, from the portfolio analysis and the literature, really to identify these gaps and to be able to drive research for the future. And finally, I would be remiss if I didn't close by thanking all of our survivors and advocates and advocacy organizations who participated in the NCI meeting, as well as the follow-up efforts, and the cancer support community and NCCS, who provided their perspectives as well as connected us with survivor advocates who participated in the meeting. Thank you very much for the opportunity to be here today to tell you about NCI's efforts in this area. And at this point, I would be happy to take questions along with Bethany. Thanks.
Thank you so much. That was wonderful. I'm so glad that you were here to share information with us to better inform us about the situation in which those live with metastatic and advanced cancers. And so I do have a few questions that were submitted prior to the webinar starting, and then we have a few questions, of course, that have come in while you all have been talking. So I will take the first question, which is a research-related question. So can you talk about the challenges of defining populations in research studies for those with advanced and metastatic cancer, and what you think we can do to create a more robust library for us to be able to support each other?
Absolutely. So that's a really great question. One of the things that we've talked about, and we could probably have a whole other webinar about, is kind of terminology and how we're referring to this population. And so we talked about this a lot at NCI, as well as during the NCI meeting. But I think identifying the population in data is key, right? So electronic health records and in registry data, we need to be able to identify that this population exists and what the prevalence or numbers really are, as well as identify them for research studies. So I will say that at the NCI, we have the SEER cancer registry data, and we are currently, we have efforts happening to advance this area in terms of defining progression of disease to metastases. Recurrence is very hard as well to identify. So I think that's an empirical question or a research question. And I'm hoping that we see some applications for looking at this further through the RFA.
Thank you. I have a question for Bethany, actually, about, you mentioned in your talk organizations that have supported you. You went snowboarding. Can you mention that organization again, and any other organizations?
Sure. Yeah. So I have a giant list from the past 4 years. So I went snowboarding with an organization called Send It. And most of these organizations specialize in AYA cancer, so adolescent young adult, which, just to recap, is generally 18 to 40-year-olds. I'm like, you guys are gonna keep me as long as I'm alive to these things because they're awesome and I meet so many people. So I did this snowboarding with Send It. I did outdoor rock climbing with an organization called First Descents. And then I've done other virtual things. Cactus Cancer Society is great. I'm actually getting published in the next edition of Elephants in Tea, which is a young adult cancer magazine, like a physical print. And I wrote a story that's getting published next month, so I'm pretty excited for that. And there's Stupid Cancer cons coming up. There's a lot of things out there to just develop that community of people who get it.
And we're really excited. Bethany is also a part of NCCS and a part of the Cancer Policy and Advocacy team, and on our steering committee. So we looked to Bethany to be able to tell us in the policy realm what is important to her and in the training that we do with our advocates. So I want to thank you too for being a part of that and being a part of our organization as well.
Yes, thank you.
Your voice really matters to us.
Yeah, I found out about NCCS through Stupid Cancer, which is a young adult program. So full circle.
I do have a question for Dr. Mollica. So, how do you see the Commission of Cancer Survivorship Program standards specific focus on patients that have completed active treatment affecting progress in this area?
That's a great question. So the Commission on Cancer's survivorship requirement is quite separate from NCI, although obviously there's overlap between the sites. I do think that we need to think broadly in terms of survivorship and survivorship care. And that's one of the reasons why NCI is committed to this definition from the point of cancer diagnosis forward. So I think we need to mold and adapt our way of thinking from post-treatment survivorship care to move it backwards to post-diagnosis. That being said, there are resource issues, right? And so that's why a majority of sites often focus on post-treatment care, but that's happening sort of at the absence or gap of individuals who are living with cancer and who are not having sort of a completion of treatment.
So my next question, Dr. Mollica, I will ask this question and then we will, Bethany, definitely if you have input into this as well. So we know that there's a lot of research on cancer rehabilitation, integrative oncology, but again, there's an access issue. How do you see those living with advanced metastatic cancers getting access, better access, and incorporating more into the regular care model?
That's a great question. Maybe I'll take a stab at that. And if you have experiences, Bethany, please chime in after me. So I think that rehabilitation and integrative oncology have been shown to be effective in certain populations. In individuals living with advanced and metastatic cancer, I think we need to develop the evidence base a bit more to be able to show that impact, as well as to identify people that need it and that benefit from it. So I think from a research standpoint, identifying sort of the unmet needs of that population and how that complementary medicine or rehabilitation works with that population to be effective is helpful. That being said, there's aspects of survivorship care, of rehabilitation in survivorship care sort of embedded throughout. So I think rehabilitation could be effective across the board. Sorry, Bethany, maybe I'll turn it to you.
Sure. So, I mean, for me, I would say I went to one of the top cancer, I go to one of the top cancer hospitals in the country, and they have these resources, but they weren't readily available or I knew about them. Like a lot of the things I've discovered that have helped are just talking to other, as I call them, cancer badasses, about what has helped for them. Like I'm part of, Dana-Farber did a young adult metastatic and advanced cancer support group. And that has been like incredible. I've made friends who not only get being diagnosed as a young adult, but also being diagnosed with metastatic or advanced. Like I've never had specific segment to be like, oh my God, you're all like me. And I mean, I don't know about like the research behind it, that stuff, but just as a person who's living with this, just having those things available, like writing, journaling, psychosocial oncology, a support system, has been hugely helpful. It's just getting that information out there. Like, I feel like it's there, but it's not being delivered to us. Like, my oncologist is amazing, but we've never talked about, like, I found out about Send It and all these things on my own. It was never information that was given to me directly.
Are there any, Bethany, are there any other other services that you deem as important to your survivorship that you've used or want to talk about a little bit more? How do these other therapies really support you as a patient?
Yeah, so for me, like I've said this, and I probably said it in that panel that we had that was mentioned, like, I think your diagnosis should come with a therapist. and psychiatrist, because as someone that struggled with anxiety my whole life, looking at a screen telling me I had a 27% chance to make it to 35 was you can't describe it. Like I can't use the correct word. I've tried through journaling and things, but you can't really find the words until you see this happen, and it changes your life drastically. This is not like anybody who gets a cancer diagnosis, it changes their life. But for me, I'll never have a point where my oncologist isn't saved in my phone and I don't talk to him every few months. That is my life. That's my reality. And it's something that I have to deal with mentally. Like I still work full time and I work during most of my treatment. And it's something that is constantly affecting my life. Like I had kidney stones and my recovery was different than someone without cancer. And I had to explain that to the urologist. Like it is something I'm dealing with constantly that brings up a lot of worry and uncertainty. So I think like psychosocial support is 100%, everybody needs it.
I wonder, can I ask Bethany a question? Is that okay? Bethany,
Oh, absolutely. Absolutely.
I wonder if you can say a little bit about your experience with primary care providers and sort of either educating them, or if you've had the same primary care provider throughout time. I know that's a challenge for all survivors, but I would imagine in this.
Yeah. Case. So I've said before, like, I don't understand why we don't interview healthcare professionals like we do somebody replacing your roof. Like you get reviews from your friends and you find out what does their work look like? What are they doing? But for healthcare providers, it's like, oh, I call up and get assigned to this person and then they're automatically treating me, which is what I dealt with when I was first diagnosed. My PCP, she told me it's depression or I'm making myself vomit every day. Like she told me I was bulimic. And I was like, I'm not, like, I don't want to live like this. And then I ended up finding a new PCP and I walked into the room and said, I don't trust you. Like, that is what I said to my PCP. And I said, are you okay with that? And I just am super blunt now with all of my healthcare providers, because I'm like, if they can't take it, they're not the provider for me. I'm going to question what they say. I'm going to make them explain stuff. I'm going to go home and look it up. I'm going to read research articles. Like I am a difficult patient, but because of that, that's why I'm still here. So it's definitely something like my PCP ended up leaving. I loved her and she went to internal med, and I did the same thing with the new person that was assigned to me. I was like, okay, how do you feel about this? Yes, I'm going to go do roller derby and probably break bones. And I have stage 4 cancer. Like, I don't care. This is my life. Are you good with that? And it's definitely been interesting. And I've had to explain neuroendocrine cancer to so many people. I know far more about it than I ever thought I would.
It is definitely a challenge as a cancer survivor myself. I have gone through 3 in the last year. So it is a revolving door. Do you see, Dr. Mollica, any, research or collaboration in this space of primary care and creating better care delivery models for cancer survivors in this space?
Yeah, that's a great question. So we did have a recent funding announcement focused on individuals with earlier stage cancer and sort of that transition to primary care or non-oncology providers. We have a few grants right now focused on that in other populations, but I'm hoping that there's some applications that come in for research focused on this topic under this new RFA, because we really need these innovative care models that center around the oncology team and this complementary med, primary care, psychosocial care, right? Really thinking about the whole person.
I have another question involving research. Is there a place you recommend for advocates, clinicians, researchers to go to look at survivorship research? And how can we be better informed of what's being disseminated from NCI in this?
That's a really great question. And I guess I might put it back to you to ask if you can share links with the recording or whatever works for you all. I can tell you that the NIH, the National Institutes of Health, publishes all of their funded grants publicly. So that's a publicly available website. It's called NIH Reporter. You can see everything that's funded. You can also search by survivorship. The Office of Cancer Survivorship and the division that we're in, the Division of Cancer Control and Population Sciences, has a way that you can actually look at currently funded survivorship grants. We also, in the literature, publish things like portfolio analyses so that you can see them. And I just saw that NCCS posted the link, so thank you so much. But that is publicly available. Also, my email address is publicly available, and you can certainly contact me if you have questions about what we fund.
So I have a question for Bethany. Have you ever received a care plan?
I have not. I didn't know what it was until a CPAT conference.
So I guess my question then, so I have never received one either. But in theory, they provide information about exercise and nutrition and other psychosocial supports. Where do you see, Dr. Mollica, how can we, expand the need for survivorship care plans and, so that everyone gets the resources they need?
Great question. So I'm going to give my perspective from a sort of research and healthcare delivery perspective, but Bethany, you might also reflect on how you think that might be helpful for you. So as you mentioned, Veronica, the survivorship care plan should include sort of your cancer history. It should include a summary of all your treatments and all the imaging that you've had. But it also should include follow-up care. So things like exercise recommendations, like you mentioned, or imaging that you need in the future, how often to see which provider. It should be a tool that guides discussions with your provider. So I think in practice, it has actually been sort of a checkbox in some situations. And so it's been limited in its use, but there are people that use them pretty regularly to be able to have conversations with their doctor. I would guess, Bethany, that you probably have a binder of everything that you've done. So you might actually have an informal sort of summary of everything that you've done. Am I right? Am I right in that?
Yes and no. So
Okay.
Everything's online, but I never got like, here's the plan written out for me. I am like a weird edge case too, because I had multiple primaries. So I was told like, we don't know how to treat you. So there's not research to back up my monitoring. So it's kind of like the tumor board, the neuroendocrine tumor board decided, here's what you're going to do going forward. But I was never given anything that says, here's the plan.
Sure. Yeah, that makes sense. I mean, survivorship care plans have typically been focused on earlier stage disease. So you're done with your early stage cancer. Here's what should happen next. So very sort of straightforward for all intents and purposes, even though it's not straightforward. But I think we need to get innovative about what we use and how we implement this for advanced and metastatic survivors.
Okay. So I have another question that kind of falls into this supportive care. So a question came in about the population, this overwhelming umbrella, and they struggle with creating support groups for this population because everybody seems to be at a different stage with different experiences, different ages, and creating a support group where it's still no one seems to fit in. Bethany, what do you think about, how do you feel about those types of situations? And have you pivoted to one type of support group or population like young adults and seem to fit in there? How did you make that decision?
Yeah, so for me, when I first got diagnosed, I joined a group for people with neuroendocrine cancer. The average age at diagnosis is 62, and about 60% of people are diagnosed as stage 4, I think was the last research I read. So in that group, it was people who were in their late 60s, early 70s that said, oh, I'm retiring. I got diagnosed. I'm just going to focus on my health. I'm retiring. I was 30. I was just starting my career in my life. So I didn't relate to those groups of people at all, despite having the same rare cancer diagnosis. It was helpful when I was dealing with like hormone treatments for side effects, or how does the PET scan, because it's a different PET scan, it's a gallium PET scan, like what do people have reactions to that? So it's been helpful for that sense, like the scientific side effect sense. But in the finding a community, I definitely found it with young adults. And that has been my focus, as well as other people who are advocating. So like with NCCS, people that are getting out there and telling their story to make a difference. That's where I've kind of found my niche. I would say people I relate to is an intersection between people around my age and people that are taking this terrible thing that happened to them and doing something to make a change. Like those have been my people.
And I think Bethany, you said something to me when we talked recently about the fact that you said, if I live long with this disease, I will commit myself to sort of helping others. You might say, I'm not going to say it as lovely as you did, but it struck me at the time.
Yeah. I mean, like, even when I wrote it out, was like, I wrote this in my article that's coming out for Elephants and Tea. I was like, I'm going to live my life with cancer. Like buckle up, cancer, you're coming along with me, and I'm living my life and making a difference.
Absolutely. Thank you.
Okay, so I have another question from, so this one I am going to direct to Dr. Mollica, but Bethany, feel free to talk. Given the challenges that we have in even getting our oncologists to refer to us to supportive and palliative care, and the lack of adequate funding for such care, how do you see overcoming these hurdles and providing long-term support and evaluation, aka survivorship care, for those of us living with metastatic disease?
It's a really good question. So we have an overburdened healthcare workforce, as we know, right? We have oncologists that are overburdened, palliative care and supportive care. I think we need to think broadly about really tailoring care to the needs of the individual, so that we're not providing this sort of one size fits all approach to everybody. We need to start thinking through that and investigating innovative payment methods so that there is reimbursement, and so that we can advocate for survivorship care. I would also say that I think the continuum of palliative and survivorship care, it is a continuum. It's all supportive care. So we need to think about the whole person and what they need.
So we've been kind of touching on it, is this idea of advocacy. And what does it mean to be an advocate? Not everyone, our survivorship survey, not everyone is going to walk into the doctor's office and be an advocate and tell their provider their true feelings. Like Bethany, when you walk in, you are upfront about what your expectations are. For me now, on my third primary care provider, I ask the question, are you comfortable taking care of me? Essentially, like, let's not beat around the bush here. And so what suggestions do you have, Bethany, for patients becoming their own advocates and feeling comfortable talking openly with their providers about the preferences and having shared decision making?
Yeah, so I'd say recommend? Yeah, for me, I was not necessarily as strong of an advocate. Like, now it's been 4 years, so now I will tell people exactly. I don't care how many letters you have after your name or before your name. I'm going to tell you how I feel. But in the beginning, it was just a lot of overwhelm, like just sense of dread and overwhelm. So I would write down what I wanted to make sure I got across with my provider. So I have a binder that I set up that I had a section for my oncologist. I had a section for my therapist. I had a section, every doctor got their own section. And the day before, or sometimes more in advance, I would go in with like, this is what I want to make sure gets addressed. And here's the questions I have. Here's what I want to make sure is covered with every provider. And I would bring that in to my appointments and I would open it up. Like I would walk into my oncologist, I would open up my binder and say, I'm going to still do this to the site and say, here's my list. And he would make sure we covered everything on that list. And I'm not willing to see a doctor who's not willing to hear my concerns anymore, because it's my, like, ultimately, yes, this is their job. They went to school for this, but it's not their life. It's my life. So just reframing how I thought about like healthcare providers was like, if I don't like you, I'm going to go find another one. Like I'm able to, I live luckily in the Boston area. So I know it different parts of the country might have a little more difficult than I do, but I can drive an hour and find multiple providers. But mine was just thinking about it in advance. I did a lot of research on like, what do you ask an oncologist? In that I did find help in the neuroendocrine community of people breaking down like specific to your cancer type, what do you need to know? Like I could react to epinephrine, which was something I had no idea, was never brought up to me with my oncologist, but I found it in a group and then was able to ask my oncologist. And it was like, oh, my tumors don't secrete this specific hormone, so I'm okay. But it is something that happens. So just mine was like, unfortunately, a lot of prep on my part to prepare for these appointments with providers and being very honest with them of like, here, I brought a notebook of questions. So my oncologist will be like, okay, do you have any more? Do you have any more? Like at this point, I've been seeing him for 4 years. He is like, what else you got for me is usually what he says to me. So finding a provider that is willing to be there for you and supportive in your care.
Thank you. So I first want to say that we have had so many questions that we aren't going to get to today. And so we have them all and we can reach out as well. I also want to, so one last question, and it involves the upcoming grant cycle announcement. Can you speak about improvements in quality of life being a strong outcome, or does it need to be related to treatment decisions or joining clinical trials, et cetera?
Great question. So quality of life is central to this whole thing. So absolutely, that would be responsive. This is not limited to treatment decision-making. It is not limited to clinical trial participation. If you, and I think we'll share that notice of intent to publish, that'll have some details in there, but once the full RFA is out, I think you'll see that it's pretty broad.
So I want to thank both of you for joining me today. It has been such a privilege to be able to hear what's going on at NCI, and Bethany, for you sharing your story and advocating for all of us. I want to make sure that I thank our sponsors who brought this webinar live for us today, and thank them for us to be able to have these conversations. And I want to say thank everyone for coming and watching, and I hope that you follow NCCS and join us and advocate for patients and survivors. Okay, everyone, have a great day.